discussing about dementia. My facilitators are Dr. Suki, and I think Dr. Prakash will be on his way to join us shortly. Right? So this will be an interactive class. So we'll be discussing, and then we'll see what the features are like. So Joe, can you take us through this, please?
So the theory of woman was put in neurological evaluation. Her brother, because of 3-year history of memory impairment, she had lived alone and maintained her own home and financial affairs since the death of her husband in 1980. The brother began to notice gradually worsening memory impairment and difficulty finding words, but the patient became angry at the suggestion that she may have a progressive impairment. Others are noted a decline in housekeeping and financial affairs, but she had no complaints. Which other history would you like to know?
Carol?
Well, so we already know she has memory impairment, difficulty finding words, and she becomes angry and agitated. You want to know, is there any behavioral changes or behavioral changes that she's had? You'd also want to know, is there any, you said difficulty finding words, but is there any other cognition? Does she get any other impairment in cognition? That is, does she get confused on and off? Does she have any, what you'd call any Parkinsonian signs? So you'd want to know, does she have any difficulty walking? Does she have any tremors? Does she have any, you'd also want to know, you're thinking this is dementia, but you'd also want to know, is there any family history of the same?
Okay. Moha?
So I think you mentioned that, so I'm assuming from this that you can still be able to do her living activities. From the way you've put it, I'm assuming it hasn't been stated clearly, so I'd like that to be clear. What she can
Well,
do.
she has a decline in housekeeping.
But she's able to keep herself tidy.
Okay, you mean upkeep.
And the other thing is, in her personal history, like to know if there have been strokes or any other conditions.
Okay, so diabetes, high blood pressure. What are you thinking about?
It's just about the multi impact dementia is another thing. So you would like to know what she's had previously in her personal history.
Okay, anything else? Would you be interested to know family history?
Yeah, Carol, I think I mentioned that.
I want to know if there's any things like incontinence, urinary incontinence, also like probably the balance.
Okay.
I think or not, does she get lost in places, like familiar places? Has she ever gotten lost?
Mm-hmm.
She can find her way back.
Right.
Important.
Okay.
Also want to know other things like, are there any abnormal mannerisms that she performs all the time?
Mm-hmm.
Are there any visual hallucinations? Anything to suggest REM sleep disorder?
Right.
What are you thinking about?
Would be like more of Lewy body.
Okay.
I'd like to know if she's seen any other doctor before this. She has what they call decline in financial affairs. I would like to establish exactly what that means, because we know that sometimes there are side effects of some drugs that may lead to indiscretion with regards to finances. And then I'd also like to know exactly how the decline has been. Has it been progressive, or has it just been like constant since the onset of these symptoms?
And why is that important?
I want to establish that's important.
She's kind of saying that there is a progressive impairment in the lubricant.
Where is the
The second aspect.
at the suggestion that she may have?
Yeah, she can tell too that it's progressive, but it's not really that it's progressive. Yeah.
Okay. Valid points. So, Apollo. What examination?
The main thing. Oh, there's a question. She was well groomed. She was a well groomed woman who was alert and friendly. General and elemental neurological exams were normal. The speech was highly anomic, an MRI basic with a tendency to use vague references such as things and stuff. She was able to provide her name, but when asked about her current age, she said, I don't know, about 8 I think. She incorrectly stated her birth month, but then became aware of this. Given 3 choices, she was able to give the correct month. She was unable to give the year of her birth, the current year, or the name of the current year's president. On formal testing, she scored well below average in all cognitive domains.
So, what do you think is going on? So,
This guy's got progressive decline.
It's a syphilis.
First name in photos. Shit happens, man.
He was buying time.
Don't worry, it's familiar. The last of my siblings to have this.
so what do you think is going on? Imran, you said,
Alzheimer's.
and why do you think so?
First of all, she's 73. She has a long-standing progressive course of her memory decline. It's not something that has happened acutely. There are no preceding symptoms to suggest any other cause of her dementia. Nothing to suggest Parkinson's in her history. Nothing to suggest other symptoms of Lewy body or frontotemporal dementia, no history of trauma. You don't know signs of any pre-existing infection, so it's like I'll go with Alzheimer's.
And I disagree.
She's highly anomic in paraphasic.
Mm-hmm.
I mean, that nominal deficiency inclines towards something else. And they're having more semantic issues, part of a cognitive decline. And although it's progressive, suggested, I don't know whether it could have been stepwise.
So what further history would you need to confirm?
For the history, I think the history would be
What do you think is the cause of her dementia? Everyone's gone for Alzheimer's. You picked up on a couple of things. For someone who's had 3 years of memory problems, she's still able to recall a bit when she's given a clue. I want to say something, Salim.
So I was just wondering with the emphasis on the expressive part,
Yeah.
or the possibility for progressive aphasia from the temporal variant. But usually that at an earlier age as compared to the Alzheimer's. And generally Alzheimer's is still the most common dementia.
Should we move on then?
Yeah. Any tests you'd like to perform, and the reasoning for the test you perform to confirm your diagnosis? You won't. Well, you won't do a test.
Well, you can do an MRI, but I think you have clear cognitive decline and no other features suggesting that you need to.
So why would you not do an MRI scan?
I mean, you look for secondary causes.
Okay.
Yeah, so that's the reason I want to do an MRI, not actually to make a primary diagnosis, but to do secondary causes. I mean, is there a impact? Could there be like other things going on in the brain that could explain the decline in cognitive decline? But despite that, I mean, with a normal MRI and normal criminal findings on imaging.
She hasn't had an MRI yet.
Okay, so we do an MRI.
So what will you be doing with that?
I'll do some imaging. We need to rule out the other causes.
Some what?
Imaging,
Which
MRI,
okay.
MRI brain, and then it's good. She's 73. You just want to rule out vascular causes, so you check for diabetes, cholesterol. I'll do the cholesterol.
So
as well,
would
and
an MRI confirm your diagnosis?
No.
Is that why you're doing it? Why
No,
are
it's
you
to
doing it?
exclude other causes.
Exclude.
Although our history is not suggestive of vasculitis, it doesn't have a stepwise deterioration.
But this history is not from the patient, so
It's from a relative.
sometimes when you get history from a secondary source, then I think there's always a chance that there might be an onset which was missed or which the patient might probably not recall or somebody did not witness. So I still think it's more to do the MRI of the brain just to make sure there is no brain insult that was missed, and of course to do the biochemical and metabolic profile that can predispose her. And also when you're putting on medication, it's important to know what is the functioning of her organs. She's 73. You probably want to know how is the kidney function, the liver function, and the electrolytes in her that could predispose her both to maintaining this illness or aggravation when you start on medication.
Great.
Also, I was thinking that before you diagnose dementia, you need to rule out secondary causes. Apart from knowing a baseline, you need to rule out metabolic causes, infectious causes, so VDRL and those things would be in order, because it's bad enough to treat dementia, you might be sick from neurosyphilis.
How about doing a baseline proper cognitive test?
That comes before imaging.
Before imaging, yeah.
But that's it, that's done then, that's why you avoid
But
it.
generally.
So does this just below average?
Which examination would you do for the cognitive examination? Yeah. So the Addenbrooke's is what we would do. The MOCA is if you're doing a very busy ward run and you can't be bothered. But yeah, the MOCA is a nice screening test, but the Addenbrooke's is what we do at your stage. But there's also the formal neuropsychological assessment. I showed you that table on Tuesday. There's like, that was like a third of the table. There's like about 20 other psychological tests you can do. There's something called the Wechsler inventory, the NOT, so many other things that psychologists use to diagnose someone's cognitive problems. And we do send people for informal neuropsychological testing that can take between 2 and 3 hours to get done properly. Yeah, so you would do a formal neuropsychological assessment. Probably we don't have such a person in this aspect of time, there's very few in the country. Anyway, for the interest of time, we'll move on.
So thank you everyone, you're all correct. So we'll start with the definition of what dementia is. So as
What's the diagnosis?
We'll find out.
Yeah, we'll find out. So as we discussed, as Jamila mentioned in her class on Wednesday, usually the difference between delirium and dementia is the progressive nature, although it's not an absolute thing. It doesn't always have to be there. So it's characterized by a progressive deterioration in your cognitive function, and when we talk about cognitive function, you need to keep in mind that there are different domains that you need to ask and inquire about when you're speaking to patients. So most commonly it's memory. You have to inquire about both short-term and long-term. Then there's language, praxis, ability to perform tasks, visual perception, and executive function. So as we've mentioned, that most of these are progressive, but they do not always have to be progressive in nature. Especially with the vascular dementias, you may get a sudden deterioration. So in terms of prevalence, when you're thinking about dementia, you have to keep in mind the age of the patient. So you can classify them based on age, and you can have those that are below the age of 65 and then those above the age of 65. So when you're thinking about patients below the age of 65, Alzheimer's is still the commonest, and so is vascular dementia. But you have to keep in mind the other dementias like dementia with Lewy body, alcohol-related, Huntington's disease, because like Huntington's, it runs within families, so it's more likely to present at a younger age. But when you meet a patient who's above the age of 65, then you need to keep in mind the Alzheimer's, the vascular dementias, and then the other frontotemporal dementia, normal pressure hydrocephalus. So you can also classify based on cause, and the reason why, like you all mentioned, the reason why we do extensive tests, is because 10 to 15% of causes of dementia are reversible. So if you're able to identify, for example, an underlying nutritional deficiency that's responsible for the dementia, then once you correct it, there's a likelihood that their cognition will improve. So we've mentioned Alzheimer's, there is cerebrovascular causes like the vascular dementias, neurodegenerative, Pick's disease is a bit rare, Huntington's, Parkinson's disease, infections.
What is Pick's disease?
TLD.
That's frontotemporal dementia. Yeah.
Pick's disease is one of the pathologies that causes frontotemporal dementia. There is pulmonary injury.
So then there's the infectious causes in our setup. The commonest is HIV, the hand. And then we have the normal pressure hydrocephalus, nutritional, alcohol, B12 and folate deficient. I mean, not alcohol deficiency, but alcohol excess. Yeah. So, and then there's traumatic tumor. So when it's so when you're thinking about dementia, when you're speaking to a patient, you have to keep in mind the various causes, and then you evaluate them accordingly. So when you're evaluating, the key is history. The key to diagnosis of dementia is history. And it's very important that you ask them, so within your biodata, age is very important, gender is important, what their occupation is. Are they vegetarian or not? That makes you think whether they may have B12 deficiency.
Why is occupation important?
Trauma, punch-drunk syndrome.
City. Yeah, like the patients who have concussions.
Yeah, so the chronic traumatic.
And also the risk that they will pose to themselves or to the in the work
Yeah, so
environment
many
going forward.
occupational exposures, that's correct. Any other?
Heavy metals?
Yes, that's exposure.
I'm talking about the dangers they may be, as in what you're establishing going forward.
I didn't get that. Okay, yeah, that's fair, yeah.
We talk about environmental exposure, so anything that can be exposed in the environment that can cause a dementia.
But I think what you meant is that there's safety, isn't it? That's what you're actually
There's
looking
safety,
at.
yes,
Yeah,
going forward.
yeah. So if you're a policeman and you're demented, and obviously you should have a firearm and things like that. Yeah, no, that's very valid.
Animals? CJD? Disease like
So no, that's true. Yeah. So again, there are all kind of different kind of occupational or environmental exposures.
Also, I think that the higher occupation or the more mind-engaging occupation, then the lower the rates. I don't know if to call it any other rates.
So that's kind of true, but you're right actually. So a higher educational status kind of protects you from a diagnosis of dementia, but even more importantly, it's more difficult to make a diagnosis. Yeah. So what happens is if you get a very high level, high functioning person, initially it may be all your tests may look normal. Yeah, and that's a big problem. I mean, all your kind of cognitive testing, because they're starting up here and you're trying to gauge them over there, and they may perform almost normally. So that's another big problem. Yeah, so that's always something to think about. So if you get a professor with dementia, sometimes it's good to look at diagnosis initially.
Sorry, is this clear for you guys? Because it's quite blurred.
I'm watching. I thought it was me.
It's only clear. He's the only one who can see.
That's not clear, I was about to.
You're wondering whether you've been called.
I think it's the. So should I continue or change?
We can change it. It's not a difficult thing.
Maybe a board that can reach.
Where's the thingy?
It's next to the lens.
Maybe it's on the side.
Maybe a tops for this one. It's on the top. Yep, perfect. Thank you.
Okay.
Is it? Yeah.
Just stay there. Okay.
Okay. So and history. You need to know your past medical history. Is this patient diabetic, hypertensive, smoker, alcoholic? What medications have they been on? And then, as we mentioned, for all the cognitive domains, you need to ask questions and then try and find out which area is their personality changed. Are they able to do their day-to-day activities? Do they go out and get lost? In your physical examination, you do your general examination. You're doing now. You're trying to test for, like Caroline mentioned, features of Parkinson's, that's going to now direct you towards, is the patient have any rigidity, patient with any focal neurologic deficits. You know, as much as patients present this way, they could be having an underlying cause also. They could be having space-occupying lesions, they could be having malignancies. And then the investigation. Now, as you all rightly mentioned, the role of investigation is really to rule out underlying causes that could potentially be reversible. Yes, in dementias you may get areas with, depending on the dementia, you may get areas of atrophy, but the role really of imaging is now to rule out any underlying causes. Okay. So when you meet patients, it's good to summarize them.
Can I just say something that another role of imaging is to kind of suggest a pattern, which may say, okay, this looks more like Alzheimer's. It's not definitive, but it does give you a kind of a suggestion. Yeah? It doesn't correlate 100% with pathology in postmortem brain, because a lot of these studies are based on brain banks, where they're collecting brain to see how correlations, how good the correlations are.
So when, as we discuss about dementia, it's also important to, after you make your assessment, it's important to now classify whether it's a mild neurocognitive impairment or a major. So when you do your cognitive testing, if decline is within 1 or 2 standard deviations from normal, and it does not interfere with the independence, then that's now classified as a mild neurocognitive impairment. But if it's above the 2 standard deviations and it interferes with the independence, then that's more likely to be a major neurocognitive impairment. And you have to rule out cases of delirium. So a lot of these patients with dementia, when they present to casualty, they actually have, with UTIs, they get worsening of their cognitive function acutely, but then after the underlying cause is treated, it gets better. And that's why it's advisable that you shouldn't do, you can do a cognitive testing when they come in with if they have, for example, a UTI, but you should retest them again after the infection is cleared, because that will now give you an idea of what their baseline really is. Okay?
When you say interfere with independence, to what level of interference should you gauge it? I mean, they have a declining executive function. Does that mean that they're not able to live alone, but they're able to take care? I don't know. How do you define interference with independence so that you can classify them as mild or major?
So, are they able to carry out day-to-day activities? Are they able to go? Are they able to take care of themselves? Are they able to go shopping? Are they able to cook for themselves? Are they able to take care of themselves, or do they need someone to be taking care of them?
So there is the more the actual battery testing. It's something that just assesses the entire activities of daily living. It's an objective list of what Karishma is saying. My sort of rough rule of thumb when taking a history in clinic is, yes, you do the presenting complaint, do the whole lot, but then specifically if it's a cognitive decline, I keep in mind the differentials, so like I said, dissolutionism, etc. The one question I do ask is, is there anything, if they come with someone, is there anything that has had to be taken over by one of the relatives or someone else because the person can't do it anymore? Yeah, and if you just leave it open at that, then you can give examples, finance, driving, looking after the house, etc. And then also, when you're asking the history, you can break it down according to the 5 domains that she's talking about. And then it's memory, but memory doesn't have to be the only reason why someone can get cognitive decline, because there's other causes for it. So there's visual perception, executive function, language, yeah. So and then the last one, you do the 5 of them, and you just try and work out from each one which one's affected the most. She'll talk about Alzheimer's in a minute, but what MCI is where mild cognitive impairment is where they have a cognitive problem, but it's not really interfering with them. Yeah, and there's even a bit before that called, I don't know what they call it, pre-Alzheimer's or something, where they complain about memory problems, but it's not. It's immeasurable. So, for example, the professor, and you measure them, and they sort of just over the average, but for them it's a bit low. So these are things to keep in mind. Yeah? When it interferes with independence, then clearly this is something that seems to be a problem. Okay.
Must they fulfill both criteria? I mean, most of the time it's like if you interferes with independence, definitely the cognitive signs are going to be really quite severe. But what if you have a cognitive sign that's not a two-standard deviation from normal, but it interferes with independence?
It's just that's it.
So it's either or.
It's either or. Well, it's either it's mild or it's maybe say classic criteria.
These criteria are also being criticized for exactly the same reason.
Yeah.
Because they're not. These things will be revised. Yeah. There's a lot of discussion. If you go to any meeting, there's a lot of discussion about this.
So in terms of the tools that you can use, we keep talking about the MOCA assessment, and I'm sure everyone has at least performed this on one patient. So it's more sensitive for the detection of mild cognitive impairment. The studies I've come across, they say that the sensitivity and specificity is about 80%. And if you look at the domains that it has, so it has memory, attention, language. So it's really all the cognitive domains that we've been talking about summarized in one table. So this is something that can be done bedside, and it can also be followed up serially. It's a more objective measure. But a more detailed is now the Addenbrook's cognitive examination, which has a sensitivity and specificity of about 90%. It takes more time, it's more time consuming, but it has a higher, compared to all the other cognitive tests done, it has the highest sensitivity and specificity. And then there's the Managemennt state exam, which has a sensitivity of about 87%. What you'll notice in all of these tests is they all look for different domains within the cognition.
Well, the criticism for this one is that executive function is not tested, so which is why we don't use this one in cognitive examination usually.
So in terms of the evaluation, okay, sorry, it's much clearer here. So basically, you have a patient who comes to you. History is your key, physical examination, and then you can run a cognitive test on them. If you suspect this patient has some form of cognitive impairment, then you can go ahead and now do your other testing, your laboratory testing, your blood count, your metabolic profile. You run your HIV test, and then you do structural neuroimaging to try and confirm your diagnosis, rule out reversible causes, and yeah. Okay. So we move to Alzheimer's dementia. Any questions before that? Something's not clear?
Yeah, it's cognitive test. You know? If you take an 80-year-old lady from from Namanga, who's probably never seen a car, and you give them a mocha, I don't know how this will do it.
So,
I mean, has this been validated in that?
No, actually, even in the mocha comes in different variants, so you can actually change the animal. They're different pictures actually. And so you're very right actually. I mean, we need to use what is relevant. Yeah. So for example, the Queen's Square Cognitive, that green book has pictures of US presidents and a British Prime Minister and the Duke of Edinburgh. I mean, they would not be relevant to somebody, out in the villages here in Kenya. So we need to use what is relevant there. So one thing about cognitive assessment, so there's a South African model of cognitive assessment which has been developed locally in South Africa by a team at the University of Cape Town. I'm sure when Herman comes back, he'll probably be very familiar with that. And there are no scores, there's no, so you just kind of use what is kind of locally available. You can even, for example, instead of, you can use matchsticks to do diagrams instead of drawing for people who are completely illiterate, So you can just put matchsticks together and just do figures, things like that. So basically, I think the lesson to learn is you have to modify to what is.
And I think we most of these patients, sometimes when we get an illiterate patient, it's very hard to do the cognitive testing on that.
Just another question. This Mocha and Addenbrooks need something, the document to be printed. And then something like the Managemennt state, I'm sure like everyone knows it offhand, like you can actually do it quite quickly, you don't have to print out anything.
I was going to say that that's the one advantage of the Managemennt, though it's actually copyrighted and we're not supposed to be using it without having that piece of paper. So it's actually, we're supposed to buy it from the company, but obviously we just ignore that you just use it. So you can do it on your own. You don't need any, you just need a plain piece of paper and you can do it. But like the words, I mean, it isn't as good as the Mocha. The Mocha is a better test and it's freely available.
And it's now available as an app, so you can do it online, the Mocha. And it's of Swahili, which is one of what Luca says.
So,
there's also a Swahili version of the MMSC. It was used in a study in QC, I think.
So we'll move to Alzheimer's dementia. So I'll move a bit
fast. Can I just say it's a proper term, the Alzheimer's disease? I know it's typically used to be called dementia of Alzheimer's type, but the current term, that is Alzheimer's disease,
So
it is a dementia.
So I'll be moving a bit fast now because of time. So Alzheimer's disease, as we've seen, is the commonest form of dementia, both in patients under the age of 65 and above the age of 65. According to the American Alzheimer's Association, it's the sixth leading cause of death in the United States. And between 2000 and 2015, deaths from heart disease have decreased, but those from Alzheimer's disease have actually increased. So early and accurate diagnosis could save up to $7.9 trillion in medical care. So just a summary of the pathogenesis. I'm sure we don't want to look at pathogenesis, but it's important. So we have the amyloid precursor protein, which is cleaved by the alpha and the beta secretase products. Now the beta secretase product is further cleaved by the gamma secretase, producing various proteins, but the toxic one that we're interested in is the amyloid beta 42. Yeah, this is now what's responsible for causing neurotoxicity, oxidative stress, and neuronal loss. So in terms of the diagnosis, again this is not very clear. So there is the dementia syndrome, and then if you want to go ahead and make a diagnosis of probable Alzheimer's disease dementia, then the criteria is an insidious onset, gradual progression, and then the initial symptoms are amnestic, which means they get amnesia, forgetfulness. No other psychiatric or general medical conditions are responsible for their condition. Okay.
And the important thing to keep in mind there is it's two domains are affected at least. It's not just memory, but it's more than memory, and that's when you pick up either from the history or the cognitive testing.
So they do mention that positive biomarkers like doing a CSF amyloid beta or amyloid PET scans. Now they may not be available everywhere. I think now the amyloid beta is available here because I've seen one patient.
CSF. Both of us worked for it, and finally they. So they charge 40,000 for doing that.
Because the one patient we had that we sent this for, it was actually the family's request that we want to know whether this is confirmed Alzheimer's, because we're not able to understand, and whether we are at risk of getting this in the future. So that's why it was done.
How specific is it?
Okay,
it's about 89%. The only problem is that I have some data, so I now have about 3 or 4 results from these tests. The recent ones. There were some older ones which are a bit more believable, but these ones I'm still a bit doubtful about them because they all don't make too much sense to me at the moment. So
is the sensitivity good?
Or the overall it's 80%. That's sensitivity is specific.
Can you use it to screen relatives?
No. But so the important thing here is that yes, you can't do all these tests, but none of these tests are 100% diagnosis. The only thing that can make the diagnosis for you is post-mortem study. Yeah, that will show you the pathology. Yeah, this making the diagnosis of the dementia, the kind of dementia someone has, is a combination of all these clinical tools you have. So the history, breaking it down into the more affected, examination, what signs do you find, focal signs suggesting stroke, Lewy body with Parkinson's, etc. Yeah, and then your examination from a cognitive assessment point of view, so your Mocha or your Addenbrooke's. Then together with that, then you add on other things, your cognitive, proper neuropsychological assessment, you do an MRI scan, you rule out other causes, you can send it for CSF if it's available. But you have to put all of those together to then say, okay, all of these are singing the same thing to me. Yeah, there's no one thing that you can do to say, this is a dementia you have straight away. And that's my approach in clinic. I say, yeah, I appreciate you have a cognitive problem, but we need to do at least these set of minimum tests to add onto that and put it together. Yeah.
The only kind of in vivo test that we have at the moment is a PET scan, which is thought to be, close to 100% specific and perhaps sensitive. But there are reported cases of amyloid negative Alzheimer's disease on PET scan, and they seem to be genetic. Yeah? So there's some genetic mutations that are, but that's a rarity. The majority of patients will be certainly positive and negative. So if you could get that, that's one thing.
Yeah.
So as we've mentioned, the role of imaging. So if you look at the arrows,
Sorry, Doctor, will it be on the PET CT or it has to be?
It's a PET amyloid scan. Looking for a specific ligand. It's called a Pittsburgh.
So it used to be called the Pittsburgh ligand or PIB, and now it's called flow beta P. But now they're actually a group of them, and
so that's really an amyloid PET. So if you look at, so it looks at optic, and a normal amyloid negative, you can see the red areas are not present, and then amyloid positive, you'll start seeing red changes. Yeah. So this is the difference. But so from the papers I've come through, they say that these tests are quite expensive and they're not readily available. So before you start sending for this, it's better the patient is seen by a neurologist who can then make a judgment whether the patient really needs this test. Okay. So the biochemical and the genetic markers, if available, you can run a CSF tau or phosphorylated tau protein, and there are certain genes. However, genetic testing is not available, and it's not really recommended.
So the CSF, it's beta amyloid to tau ratio. That's really the most sensitive and specific test. Beta amyloid to tau.
So in terms of treatment for Alzheimer's dementia, now you can use acetylcholinesterase inhibitors like donepezil, rivastigmine in mild to moderate neurocognitive decline. But then if someone has severe neurocognitive decline, then there's a role for using memantine. But you'll have to keep the common side effects in mind and keep monitoring patients for them. If the patient has psychotic features, then it's recommended that you start the patient on an SSRI, or if the patient has psychotic features, then you can give them olanzapine, risperidone. But if they have depressive features, then you can consider an SSRI. There's something called ginkgo biloba extract, which may improve cognitive function. I don't know what the mechanism is, but this is...
No. So there's no those things actually work. It's very nice to give people, here's some neurobiome, neurolubine, and some vitamin B, but none of these things work, and there's no evidence. Ginkgo biloba used to be a fad, but we know now it doesn't really help much in terms of Alzheimer's, certainly.
Just make one comment about antipsychotics. Antipsychotics are a double-edged sword, and there are many studies suggesting that they increase mortality in elderly people with dementia. But there are some studies suggesting that they don't. Certainly, so they have to be used with a great deal of caution. Obviously, they can cause fibrillation. Elderly patients are not only pharmacy, but that's another problem. And then they can make somebody who is mobile Parkinsonian. So somebody may have some hallucinations, but they're not too bothersome, or some delusions, but they're not too bothersome. They just have to lock the door or something like that. But then you're making them slow and they can hardly walk. So you're balancing these things. Yeah.
So, in terms of management of Alzheimer's dementia, yes, they're the medication, but the most important is coordinating care amongst physicians, because these patients need, nurses, and as much as they tend to get quite confused when they're in a new environment, so you need to make sure they're in a familiar environment. And you'll notice a lot of these patients, when they come to the hospital, they're very agitated. So that's one. And then you have to make sure that they're in a safe environment. So
there's some new research on dementia and Alzheimer's and gingivitis.
It's very
Yeah. So there has been this long-standing thing about dental issues and so periodontal disease actually, and both vascular disease, cardiovascular disease, and neurodegenerative disease. So now people have identified some of these gingival organisms in brain biopsy tissue, in post-mortem brain tissue.
Can I skip the case presentation?
You can. You have less than 10 minutes to go.
So I'll just skip the case presentations, but the slides will be available. So this case was looking at vascular dementia because of all the risk factors that I mentioned.
Yeah.
So in terms of diagnostic criteria, now one misnomer about vascular dementia is that you have to have had a stroke in the past, which is not true. If someone has the risk factors that predispose them to getting atherosclerotic or vascular disease, then you can make a diagnosis of vascular dementia. So as per the American Heart Association, if you have imaging evidence of cerebrovascular disease and there's a clear temporal relationship between a vascular event, so a patient got a stroke 5 years ago, since then their cognition has been declining, then you can make a diagnosis of vascular dementia. The other thing is the territories where the stroke has happened is also very important. So a lot of the times, if you've had an infarct in the medial frontal lobes, the thalamus, or the medial temporal lobes, then they're more likely to predispose you to getting dementia in the future. So in terms of treatment for this, you tend to treat the underlying cause. So your aspirin, your statins, you just treat as you treat a stroke. There's no specific advantage of giving them anything else. Because it's neuronal loss. When you get an infarct, you get neuron loss. So, okay, my computer is stuck. Sorry, you can be. So we can be reading this as my computer decides to. So disconnected.
Is it moving now?
It's processing. It's demented. Yes. Okay. As it decides to function, yes.
So Jordan, you're almost towards the end, isn't it now?
Hang on, it's saying something there. I'll quit and start again, maybe. Yeah. You have to unplug. Oh well.
So this computer is not demented. This is just a moment of maybe a seizure.
didn't operate a virus. It's a Mac, so it's not going to get a virus.
Can I ask on the epidemiology? I should get this sorted. So, she said that the causes of dementia have gone, the cause of death, dementia as a cause of death has gone up by 123%. But I was wondering what actually causes death in dementia patients? Is it actually the dementia or is there other comorbidities? Because I think they get more heart disease, they get more aspiration problems, so pneumonia and infections and everything because they move around. So is it actually the dementia itself or is there other things on the line?
It's a very good question, but I mean, so I think there are two ways of looking at it. One is it's the people who survive cardiovascular disease who seem to get the dementia, isn't it? So if you get a heart attack at 50, you're unlikely to get dementia. You die from it, you're unlikely to get. There's the people who successfully survive cardiovascular disease and all that, they tend to get the dementia. So many of these people with dementia will actually die from the dementia, but not, I mean, eventually they're immobile, so they'll get an infection, sometimes respiration, pulmonary embolism, something will happen. Yeah. So even though it may not be the immediate proximate cause of death, it is the cause of death.
Yeah.
So sorry for the hitch. So we move to frontotemporal dementia. So frontotemporal dementia has 4 subtypes: behavioral, fluent, non-fluent, and for frontotemporal dementia with motor neuron disease. So if we look at the behavioral variant, their classic features are disinhibition. So they tend to have more of a personality change. There is apathy and hyperorality. They can even eat rotten food and so on examination, they'll be restless, inappropriate behavior with or without poor grooming, and neurophysiologic testing, although not available here, will classically show deficits in executive function with tasks, but their visual spatial domains will be intact. So if you look on the image on the right, you'll see there's marked atrophy on the temporal frontal areas. Then there's primary progressive aphasia. So when you're thinking of frontotemporal dementia, you need to think about their speech. Are they able to comprehend? Are they able to articulate their speech? So in primary progressive aphasia, they get anomia and single word comprehension deficits. So in the first case that we saw, there was mention of anomia. When you do a neurophysiologic exam, there's deficit in single word comprehension when asked to define single words. So if I ask you, what's a table? You have they wouldn't know what it is. Then the non-fluent frontotemporal dementia, what tends to happen is their comprehension is intact, but the problem is their speech production. So they tend to get a lot of grammatical errors in spontaneous speech and frequently include omission of small and close class words, for example, and, or, the dropping of verb endings and errors in verb agreement. Okay? So I know you must be thinking, why have I brought a Parkinson's plus syndrome here? But actually they've now started to classify it within frontotemporal dementia as one of the variants. It's not a variant.
Well, it's a cause of because so this is the joy of brain banks. Yeah, I mean it's a morbid business, but basically you collect brains from patients who have died from this thing. And then now you correlate what you had clinically, so you're very good clinical data, and you correlate that with pathology. And then you find, all these patients we were calling frontotemporal dementia, this percentage actually had PSP pathology. So now you realize that PSP can present as frontotemporal dementia and also as a Parkinson's syndrome.
So patients with PSP classically present with increased axial rigidity of the neck and trunk, slowed vertical saccades, dysarthria, apathy or depression, and general slowing of speech and thought are observed. Yeah. So I know we don't have time, but what have I circled? What's that sign? What's that sign? It will come in an MCQ.
There's one sign that's usually in clinic for this. You can ask the patient to do. You mentioned it. There's no applause sign. So ask them to clap 3 times. And I think it's a PSP, right? That it's called the applause sign.
And then I think there was a video you showed us. Was it metallic apraxia? I'm not sure.
Magnetic
apraxia.
That was for corticobasal degeneration. Yeah.
So the next thing is corticobasal degeneration. We actually even had a patient with this last year, and he had presented with an alien limb. He also had myoclonus. So then they also have behavioral features and language features, and this is why you can see there's an overlap with frontotemporal and these. So in terms of the treatment, it's not very different. You use the same SSRIs and like atypical antipsychotics based on.
The key thing is we don't have a treatment. Yeah? We have symptomatic things we can do, tweak this or that, but we don't really have a good treatment.
So, HIV-associated neurocognitive disorder. Now, it's common in our setup, but we don't screen for it. In our HIV guidelines, there's no screening for HIV-associated neurocognitive disorder. So again, it's classified into asymptomatic, mild, and HIV-associated dementia based on the cognitive impairment and whether it interferes with activities of daily living. Okay. However, before you make a diagnosis of hand, you need to rule out all the underlying causes that could present as hand, and patients with HIV can present with opportunistic infections. Yeah. So you need to rule out your toxo, you need to rule out your crypto, you need to rule out your CMV. The list is endless. Now, in terms of treatment, so who do you screen for it? Now in Kenya, we have no guidelines. According to the IDSA, anyone with a CD4 count of less than 200 should be screened for HIV-associated neurocognitive disorder. According to the South African journal, the South African guidelines, the CD4 count is less than 350. Now, based on the study that Violet did for her dissertation that she did in the HIV clinic, she noted that there was no association between a mild cognitive impairment and adherence to ARVs, and that's why it's not routinely part of our HIV package for patients that have been diagnosed with HIV. So the treatment really is early initiation of highly active antiretroviral therapy, and you can use different, again you can use the MOCA, there are other scales that can be used, and then they can be followed up in subsequent visits. However, keep in mind you have to rule out opportunistic infections in these patients before you start using this. Now it's 9 o'clock. Do you guys want me to continue or? We started at 8:10. Okay, we continue.
Now I'm gonna have to leave soon, but I can go for another 5 minutes. I don't know how many slides you have left.
I have 10, but they're quick.
Okay.
So next is normal pressure hydrocephalus, which is a triad of dementia, gait disturbance, and urinary incontinence. Now, there's something called an Evans ratio, which usually the radiologists employ to try and get a ratio of the ventriculomegaly versus the size of the cortices. Yeah. So anything above 0.3 tends to point towards a ventriculomegaly. Now you need to keep in mind that patients with brain atrophy, when you do an MRI, it may appear as ventriculomegaly, right? So that. Now in terms of their gait disturbance, they can find difficulty in transitioning movements like sitting to standing or standing to sitting, great initiation failure, shuffling, poor foot clearance. So you may confuse this with Parkinson's. But the thing is that when we talk about urinary incontinence, so urgency and frequency are the most common urinary symptoms, and they may occur with or without incontinence. So patients are usually aware of the urinary urge and are concerned about their incontinence. If you have a patient who is not aware of the urinary urge, then it's unlikely to be normal pressure hydrocephalus. So there are differentials that I'll leave you guys to go and check. Now the treatment is insertion of a ventricular shunt. Now a tap test is a simple test. Now patient has all these three features. You do a CSF tap for them. You drain about 20 to 30 cc's. Then you observe them after you drain for the next 2 to 3 hours. Are their symptoms resolving? If their symptoms are resolving, then they benefit from a BP shunt. Okay? Or they can have external CSF drainage.
So it's coming out now, and what we've seen in experiences in many of these patients may have double pathologies. So they may have normal pressurized catheters, but they probably have another, neurodegenerative disorder. So you may often have dual pathologies, and that's if you do more recent, the current.
Sorry, Karishma, we'll have to just leave. I'll let you finish with Dr. Wu. Okay. Yeah. Okay. The feedback is sent on me, is it? Okay. You should be next.
So, the other thing we're going to talk about is Lewy body dementia. Imran has already alluded to it. But really, in terms of, for you to make a probable diagnosis of dementia with Lewy body, you need 2 out of 3. Lewy body. Sorry. So you need presence of dementia, and then you need like fluctuating attention and concentration, features of visual hallucinations, spontaneous Parkinsonian motor signs, most commonly rigidity, and then, as Imran mentioned, the rapid eye movement sleep behavior disorder. Okay, and then if available, you can do a SPECT and PET scan, and then you'll see there's reduced uptake in certain areas. Yeah?
So this is dopamine, yeah? So
Dopamine, sorry.
Amyloid, now you're looking for dopaminergic dysfunction.
Okay, so the others that I've added additional slides that you guys can check on the others, and then for further reading. So there's niacin deficiency, which presents as dementia dermatitis, photosensitive dermatitis. There's prion disease, I can't pronounce it, CJD disease, limbic encephalitis.
It's Creutzfeldt disease, yeah?
Vasculitis, and then there's Huntington's and dementia. So, in summary, dementia is a syndrome characterized by progressive deterioration of cognitive function. They may also present with neuropsychiatric symptoms, apathy, agitation. They actually tend to get worse in case they have an infection. But history is key to making a diagnosis of dementia. And I'd like to emphasize that multidisciplinary approach in the management of these patients is very, very important. Yeah. So that's it. Questions?
Can I just say something about prion? So the prion hypothesis is now central to all the dementias, all the neurodegenerative dementia. And indeed now is infiltrating even diabetes and cardiovascular disease. So it seems that these pathogenic proteins, or if we think, and they kind of are amyloidogenic and they kind of spread, so they almost spread from cell to cell in a prion-like fashion. So even in the non-infectious dementias, there seems to be a prion-like process going on. But obviously the prions are proteinaceous infectious diseases, and they're very, very, they're a big danger. For example, they can't even, you can't even get them with transfusions and tissue transfers. Within a couple of reported cases with IVIG. So there's all that problem with the parent.
So, limbic encephalitis is one of the potential causes. So autoantibody testing, should it be more routine? We're getting more limbic encephalitis, presenting as seizures, normal behavior. in a selected fashion.
Sure, yeah. So one should screen for autoimmune encephalitis in patients with rapidly progressive, dementia, certainly at any age. Sorry?
Should we also make taps routine?
So in rapidly progressive dementia, yes. Yeah. I mean, a classical history of Alzheimer's disease really subjecting the patient to a lumbar puncture is such a pain, yeah. But in a patient who has a rapidly progressive dementia, certainly it happens. Anything atypical, young onset, yeah, it happens. Because the other thing is like a vasculitis is one of the things that, I mean, if you have a cerebral vasculitis or something, I mean, we have had a patient with cerebral vasculitis recently. I suggested a biopsy and then unfortunately don't forget about that when it's restricted. So because ideally you should do a brain biopsy in this patient. So this patient is rheumatoid arthritis, came in with a cognitive motor declines, subacutely over weeks, and he had multiple brain lesions, and then we actually treated with cerebral vasculitis and much better. So that happens. That's the other thing to understand. He had all the autoimmune, the encephalitis came, nothing came.
Okay. Thank you, everyone. Thank you.